Thank you very much, Jen, for the most generous introduction. And I would also very much like to thank the organizers for inviting me to speak here. It's a true pleasure, and it's always a great pleasure to be at the BIPC meeting. I'm going to talk about post-traumatic stress disorder and the path really that we have taken in trying to come up with a treatment program that treats PTSD effectively. But as Jen just said, we are also increasingly concerned about efficiency of treatment delivery so that we can help more patients. So I'm going to take you through this journey a bit with me. But our group obviously is not alone in going on this endeavor. I just wanted to show this graph plotting effect sizes in CBT treatment for post-traumatic stress disorder over time since the 80s, when people started to work more on PTSD, and over the years when randomized controlled trials were published. And I think you can just eyeball this and see there is progress in the field. So we as a field have got much better in treating post-traumatic stress disorder and getting people better with greater effect sizes. This slide illustrates really the same point, but now also putting it into the perspective of other treatments. Two meta-analyses of the effects of pre-post treatment effect sizes for various treatments, one published in 1989, so one of the early CBT programs, already actually, as you can see, showing quite good, actually very, very large effect sizes statistically, but also clinically meaningful effect sizes already in the early days. But as you see the increase there in 2013, again, an increase in efficacy of the treatments. So how did we get there? Oh, sorry, and I also wanted to actually point out importantly that the same pattern of which treatments actually help with PTSD not only applies to a single event trauma or very discrete trauma, but also applies to chronic disability from childhood sexual abuse. Here's a meta-analysis that Thomas Ehring and colleagues published in 2014. And just to point out that in the trauma-focused CBT overall had effect sizes between 0.88 and 1.72, depending on what the comparison was. These are very good effects and clinically meaningful effects, even in this very difficult to treat population. I said, how did we get there and what are our future challenges? So the first point I want to bring across that in our experience, the increase in efficacy in treating PTSD has a lot to do with developing very targeted interventions for core symptoms, and I run through the example of Reexperiencing symptoms here. Second point I would like to make is that we also as a field have to always bear in mind treatment acceptability, and advances have been made there. I will then look into how do the results from the clinical research studies and trials transfer into clinical practice. Can we get similar outcomes in clinical practice? Briefly mention research on investigating psychological mechanisms and how they can help us improving the treatments further. And then I'll come to the topic of efficiency, addressing the problem of limited resources. So to start with developing targeting intervention, and here I would like to emphasize the role of really understanding re-experiencing symptom in PTSD, the very core symptom that is crucial for the diagnosis of these conditions are recurrent intrusive memories of the event or re-experiencing physical sensation or emotions from the event. And in looking at the phenomenology of re-experiencing symptoms, we were actually struck that people do not remember the whole trauma in these kinds of intrusive memories. That is usually the intrusive memories are about very relatively brief moments from the trauma that we then want to look at further. And the example here is like an example, let's say an assault survivor who was attacked in her house. might have a brief moment when the perpetrator looked through the letterbox before he broke into a house and attacked her, coming back again and again in this intrusive form, and a few other moments of the memory. But often it is about moments shortly before things got wrong or before the meaning of the event got worse. What is also striking about the re-experiencing symptoms that we have to understand theoretically, but also then address in treatment, is that the emotions that people experience during these intrusive memories are first of all very strong, but they also, very interestingly, the original emotions that people had at the time. So even though people know that they haven't died in the trauma, for example, they may still have the overwhelming fear of dying that they had at the time when they have re-experiencing symptoms. So that's something psychologically very interesting, I think, and that could help us get clues for the treatment. And overall, it is the case that people with PTSD, when they have these intrusive memories, have often limited awareness that a memory has been triggered. It seems to be all happening in here and now. People describe it, it's as if it's happening in the here and now rather than a memory in the past. And the most extreme example of that are dissociative flashbacks, where people are really back in the event and act and behave as if the event was happening again without awareness of their current surroundings. So why is it the case that the memory content appears to be in the here and now? We have looked at this in detail in our work, and other people in the field have also been very interested in this question, and a lot of controversy has arisen about what the main causes of this phenomenon are. Our idea, we were able to narrow it down to the hypothesis that it is really about the memory for the worst moments that come back in the experiencing symptoms, that these moments are disjointed in memory from other autobiographical information or even from what happened before and after in the trauma. So coming back to the example, they know they haven't died, but still when they have this moment, they can't access, so this moment is so disjointed in their memory from what happened before and after, that at that moment when the intrusive memory is triggered, they don't access the information, I didn't die. Or if it's something from the event itself, so for instance an assault survivor who blames herself for not fighting back more, may not access at the moment when she is very ashamed for complying with what the perpetrator asked her to do, that might not access other information from shortly before, where the perpetrator threatened her with a knife and said, I'll kill you if you don't do what I say. If you put the two together, her behavior is very understandable, and she actually might have saved her life by complying with his requests, but that is not retrieved in this moment, and she feels very ashamed about complying. And this disjointedness in memory has the effect that we call it the memory is not sufficiently elaborated, and more precisely, it's not linked with that information that would make the meaning of a situation less threatening in the present. So we have phrased it as saying the moment remains threatening as the meaning hasn't been updated. So there's lack of updating of these worst moments in the trauma memory. And we have some empirical results to support the idea that it is really the disjointedness of the memory rather than other aspects of poor recall, when people have like gaps in memory, let's say, or can't quite remember the order of the event. These may also be relevant for the appraisals of the trauma that a person has later on, but they are less important for explaining the re-experiencing symptoms in our data. And here is a slide showing you results from a recent questionnaire study that Juliane Sachschal did in my group. And we have in red people who have been reporting about the disjointedness of their trauma memories, and in comparison to in yellow to another negative event. And you can see that in people with PTSD, the disjointedness is much greater for the trauma than for other negative events. and more so than the difference bigger than in traumatized people who don't have PTSD, and there's no difference in controls to be expected, talking about two different negative events. And as you can also see then on the right, is when we treat people successfully, this disjointedness goes down and is much reduced. And how do we achieve this? So this idea that the worst moments in trauma are not sufficiently updated led us to a systematic 3-step procedure where we first access the worst moments in memory, identify them, and then discuss with the patient the idiosyncratic meanings of these moments. And then we, in the next step, in the discussion with the patient, we identify information that updates these meanings and impressions and predictions at the time. So in this, let's take the example again, the lady who was threatened with a knife. She identifies, oh, actually I complied with the perpetrator because he had threatened me with a knife. My behavior is very understandable, so there's no reason to be ashamed about. And in the discussion with the therapist, that kind of shame may already reduce a bit, and the conviction that she disgraced herself in the assault is also reduced. But often we find that there is still for an emotional shift, it needs another step. And that's why we have the 3rd step, where they actually then link that particular information in with the worst moment in memory. So they simultaneously bring to mind the worst moment, the hotspot in the memory, and then bring in simultaneously into their mind what they know now, that it was because she was threatened with a knife. And this can be done verbally, with imagery, or with moving about. For instance, somebody was afraid they were going to be paralyzed in assault. They can fear the movement of their body and really convince themselves that way that the worst thing they feared didn't happen in the assault. And I said, for this emotional shift, we really need this 3rd step, and this result from a study that Elizabeth Woodward published last year brings that home a bit. So clinically in the session, we see this emotional shift. You can see the patients really visibly being relieved or even surprised about when they link the updating into the hotspots. But we can also see it in the symptoms. Usually when that's done successfully, you see a big drop in symptoms. And in this example here, we have had sleep diaries and to monitor how well people slept. And as you will all know, people with PTSD have very poor sleep. And you see here on the left that and we had daily diaries because we were doing an intensive treatment in the study. And what you can see from the day before to after the updating, you see an increase in sleep duration of over 40 minutes. And then if you look at the control days when no updating was done, there was no change. So we get big changes in symptoms and emotions with this updating procedure. Now, another aspect of the re-experiencing that we have looked at and carefully is the triggers of re-experiencing, because people with PTSD will often tell us that the re-experiencing symptoms came out of the blue. They were actually not very anxious at the time. Everything was going fine, and suddenly they were hit by these intrusive memories and these strong emotions that come with them. And by working with many patients, we found that the triggers are often don't have a meaningful situation. They just happen to be, they are about stimuli that happen to be around the time when the trauma happened. And more importantly, or even the similarity to the stimuli they counted in the trauma might not be very big. And it's just like one sensory overlap. So it could be just a particular color, but everything else is different. Or it can be a particular sound, or a smell, or taste. And they can be in a completely safe situation, but still that one similarity with the trauma is enough to trigger intrusive memories that gives them the sense that something terrible is happening in the here and now. And we have looked at the memory processes that may underlie this phenomenon that it is these kind of very the sensory cues that are so important in re-experiencing. And we have identified two very basic learning mechanisms that play a role here. I can't go into much detail. One is perceptual priming, which you could say is like a perceptual fine-tuning. So we have found in experiments that if people are exposed to analog trauma like unpleasant films, that the perceptual threshold for being able to spot similar stimuli that were around in these analog stressors are more easily spotted than if they control stimuli. And I call it, it's like a perceptual fine-tuning. So after trauma, their sensory system is adjusted so that they can more easily spot similar looking or smelling or tasting stimuli. And and in addition, there is a generalization of associative learning that also plays a role. And both of these learning mechanisms have the effect that there is poor discrimination between the original trauma situation and the situations that patients encounter now. It is really only an overlap that is very minimal very often. And this is just an example of this perceptual threshold adjustment. So you probably can't see much what is on this slide. It's kind of a blurred slide. And if we show blurred slide like this, and that this is like, this example is a kind of a car that has been in an accident, people with PTSD will be more likely to identify them than other people who have had similar traumas but don't have PTSD. And this is illustrated in this slide from a study that Bert Klein and Thomas Ehring did in our lab, where people saw trauma-related pictures like you've just seen, general threat pictures, and neutral pictures in blurred form. And the bars just represent the percentage or the likelihood of identifying these pictures. And you see people with PTSD, the red bars, were better at identifying the trauma-related pictures than the people without PTSD, no difference in the general threat, and for neutral pictures it was actually the other way around. So the whole perceptual system in PTSD people seems to be fine-tuned to spot reminders of a trauma and to the detriment of all the neutral information that's around them. The therapeutic technique that we have developed from the work with the patients and the experiments is a stimulus discrimination procedure where we work with patients in a kind of detective work. We work collaboratively with them to identify their sensory triggers that are relevant for their particular re-experiencing symptoms. And then we break the link between the trigger and the current situation and the trauma memory by really tuning in on all the differences. There's usually only one a stimulus that is one part of the situation that is similar, but everything else is different. And it's an intentional training to discover the differences in the current situation, realize that a memory is being triggered, look at the differences, and really observe the context in which they are now rather than in the trauma. And this is practiced first with the therapist, but then also at home. I don't have time to talk about all the treatment procedures, but the idea is of developing other treatment procedures in our program has been very much focused on the phenomenology that we see in patients and then see what do we know in psychology that could help us explain the phenomenon and then come up with interventions that address it. So this is now a slide that shows the overall treatment model that we're using in cognitive therapy for PTSD. I have talked about the left-hand top side, the trauma memories and the triggers. So we've talked a bit about how understanding the disjointed nature of the trauma memory and the sensory nature of the triggers generated treatment procedures where we elaborate the trauma memory, do this updating procedure, discriminate the triggers. But another big source of current threat in people with PTSD is the appraisals, the personal meanings that people take away from the trauma, what they they think that trauma means about the world. It could be, they might perceive an external threat, like I'm going to be attacked again, the next disaster is going to strike too, and I will not live long. Or even more importantly, I think in PTSD, the appraisals about the self. What did the trauma reveal about me that's threatening in the present? So it could be something like I'm inadequate, I deserve bad things happening to me, I'm worthless, and so on. And both the trauma memory and the appraisals work together in creating a sense of current threat that then is accompanied by intrusive memories, strong arousal, and strong emotions. And in my examples I've given you, I've already mentioned that it is not only fear that we're dealing with in PTSD, but people with PTSD have a whole range of negative emotions that can be triggered by both the memory and the appraisals. For instance, shame, guilt, anger, and so on, disgust as well. So these two sources of threat we're going to target in the model, but then finally there's no change in the trauma memory and the appraisals because people will use a whole range of cognitive or behavior strategies to keep the sense of threat at bay, and they are very understandable. People feel very much in need of something that helps them cope with the threat they are perceiving, but unfortunately they maintain the problem, and so we have to work with them on developing alternatives and giving up these maintaining behaviors. So we have, this is a very complicated slide, and I don't expect you to understand that every detail. Let me take you through this. So I've showed you a little bit of data, but it's just, this is a recent study we've done analyzed of 702 trauma survivors that we recruited in A&E, and we tested whether the model is kind of gives a reasonable fit in explaining who will have PTSD in the long term. So this is basically the model you've seen flipped sideways so that we could fit everything on the graph. So on the right-hand side, so you see the outcome, persistent PTSD symptoms at 6 months in this cohort was explained really quite well by the appraisals and memory. They are in the second row there, and then the behaviors that people take in response to the appraisals and memories features, such as safety behaviors, responses to intrusive memories that includes thought suppression and rumination and numbing, intentional numbing, and also dissociation. And the variance that was explained was 52%, which is really quite large for a study like that, and statistically that was also a very good fit. So we are constantly fine-tuning and testing our ideas, and it was reassuring to see that people with trauma survivors who are assessed very early on after trauma, then if you measure the factors that we put into the model, that we can explain PTSD quite well. You will also see here on the very left some cognitive processing styles that we have looked at in PTSD, like what goes through people's minds during trauma, and there's concrete hypotheses about how they are linked to memory characteristics and appraisals, and they also contribute a lot to the prediction. So even if we only measured what goes on in people's minds during the trauma, we have quite a good prediction of who will have long-term PTSD via these appraisals and memory characteristics. And I just wanted to mention one here. You see mental defeat, and we'll come back to that when we talk about treatment dropouts or non-responders. Mental defeat is a state that people describe especially in long-lasting interpersonal trauma, where they get a sense that they're really not a human being any longer. They give up any inner resistance and really feel like they're only an object that's kind of manipulated in this horrible situation. And we found originally that this is a predictor also of poor response to exposure therapy, which then motivated us to develop procedures for these people. So we can actually these are different concepts that we can also measure with questionnaires, for instance, and then do predictive work. But coming back to treatment now, what happens in cognitive therapy for PTSD? We do an individualized case formulation. We do quite a lot of reclaiming your life assignments throughout treatment, where we encourage people to reclaim things from their former life, their activities and social contexts particularly, or exercise that they've given up since the trauma, or rebuild their life if it has been very long-lasting trauma or lots of losses involved. The updating memories I've described, identification and discrimination of triggers I've described, and we work on modifying the appraisals that people take from the trauma, personal meanings, and maintaining behaviors. We also do a site visit where we take people back to the site, and for various reasons, partly to really, as the ultimate then versus now discrimination, looking at the site now shows that it's very different. Life has moved on, and it really brings home the message that traumas in the past. And we do a blueprint at the end about what people have learned and prepare them for any setbacks they may have. I should also say that the treatment very closely interweaves the memory work with the cognitive work. I hope that has become clear in the description of the updating memory procedures. And it's also tailored to the particular interpretations or appraisals that people have and the corresponding emotions. So if somebody is concerned about external danger, another bad thing happening to them in an overgeneralized way, then behavioral experiments are essential, where they test their predictions. I'm going to be attacked again, for instance, while dropping their safety behaviors and their hypervigilance. If somebody is particularly ashamed about certain moments in the trauma, we find that surveys where people discover other people's views of the situation really help them see it in their own concerns in a different light, and see that the people are not as hard a judge of their own reactions during the trauma or their behavior as they might fear, and so on. So for anger, we find it useful to write an anger letter where the client really gets a chance to be heard about all the things that have been so difficult by the trauma, how the trauma has affected them, but usually that's not sent, and so on. So there's particular strategies, cognitive strategies, that are particularly useful for certain types of appraisals. But it's also probably quite important to say that there is quite a lot of trauma-focused treatments that are available now. How does this approach differ? So, for instance, we do not use repeated exposure to promote habituation as a mechanism of change. Instead, we do the updating memory procedure. We don't really do exposure hierarchies by anxiety level, but we really work on the triggers and the stimulus discrimination instead. And in difference to other cognitive approaches, we don't really do regular thought records because we work so much with the thoughts that have to do with the trauma, so that we're working more really in close connection with finding those worst moments in the trauma. And we also don't do kind of positive self-talk or self-instruction. So there's quite a lot of differences as well. And the treatment works. Here's the results from one of our trials. The results in other trials are very similar. This shows results from a trial where we compared cognitive therapy given in a weekly fashion over 12 weeks. This is the red line, and you can see very large changes in symptoms. So the effect size is around 2.5 in this trial and in others. First of all, let's talk about the comparison groups. In black, we have a waitlist group, as you can imagine, or would expect in chronic PTSD. You don't see much of a change with just waiting for treatment. So most of these people needed treatment afterwards. Then there's a green line, and that shows a psychological control treatment. an active treatment, supportive therapy that focused on people's emotions and changing emotions. And as you can see, that also worked pretty well and got about, I think we had 43% people also recovered with this treatment. So it is possible to treat some people with PTSD with non-trauma focused therapy, but also you see there's big differences. Cognitive therapy did much better, and we had over 70% people recover. And then the orange line is a variation of the format of treatment. We had an intensive therapy condition where people were receiving the same treatment, so no saving in therapist time here. So the therapist saw the patients in over 5 to 7 working days and for several hours a day and over a week, basically you could say. And most of the therapy was done then. There were some further sessions later on, but overall the time spent treating somebody in weekly treatment was the same as in the intensive treatment. And as you may expect, by that more treatment was given at the beginning, people in intensive recovered faster, which is a benefit. And overall that they achieved the same outcome as those treated in weekly. So this is one example. The variations in the delivery format may help address or cater for some patients' preferences in future work. And this is just a summary of all the effect sizes we found in various studies. And as you can see, the cognitive therapy program works well. Effect sizes on average around 2.5 pre-post treatment. And this is larger than was observed in the previous work in the meta-analysis. Let me now turn to treatment acceptability. This is something that I have been particularly interested in kind of getting the balance right between doing an effective treatment that works for people, but also a treatment that people can tolerate and accept. And there is quite a lot of heterogeneity in the results that have been published in the literature. Overall, psychological treatments do quite well. Only 13% dropouts in RCTs, which is, I think, still in the acceptable range. But there is a large heterogeneity, and some trials report dropout rates of 25 to 40%. And that shows that that means that the treatment didn't work for everybody. Some people may drop out early because they are better, but most people who drop out actually are not better, and then they have a failed treatment attempt, which could be a problem. So we were very, very keen to develop a treatment that really is very acceptable, and overall in our trials the mean dropout rate is only 3%. In the latest trial we had 7%, which was the greatest number we got. So it is an acceptable treatment, doing the treatment that way, and it's better than medication treatment. But what can we do how can we get there to increase treatment acceptability? And I think people who have successfully done this have taken two different approaches. I have described our approach to doing really very targeted treatment to the symptoms and then delivering it in a format that is acceptable to patients. But other people, just to mention, have taken other approaches. For instance, Marilyn Cloytra has worked with survivors of sexual abuse and has found that if she does some skills training before doing prolonged exposure therapy, that can help with acceptability. And Frank Neuner and the Constance group around Thomas Elbert and Margaret Schauer have developed narrative exposure therapy, which is directly targeted at people with refugees and multiple traumatic events. So I think you can go either way, but we should, as a field, bear in mind that the treatments that we are developing and disseminating have a good acceptability for patients. And I mentioned the example of mental defeat earlier, and that we had worked with Edna Foer on a study of poor response to prolonged exposure. And in this very early study, we identified that mental defeat was a strong predictor of non-response. And we also then, in the following studies and in the last study, a prospective study I showed you, has a very big effect on predicting PTSD after interpersonal trauma. So our conclusion from that work was that if we have a patient with mental defeat, we know repeat exposure is not likely to affect their cognitive patterns and lead to change. And so we have really worked with those people in a more cognitive way, and also when we kind of accessed the trauma memory, looked at it more in a meta perspective, and always bearing in mind the perpetrator's contribution, or focusing on that, rather than only focusing on how they are feeling at the moment. And having this kind of wider perspective then makes them realize, oh, this is actually something the perpetrator wanted to achieve. He wanted to humiliate me. He wanted me to feel like an object. And that when they look at the situation that way, that seems to be more effective than just reliving that moment where they felt they had completely given up and they were not a human being any longer. So analyzing causes for non-response or dropouts, I think is an important way to go. Okay, so we've talked about the research leading in our example, but it can be applied to, obviously, to other forms of treatment of PTSD as well. We can fine-tune our treatment procedures so that we get an acceptable and effective treatment. In the research context, does this generalize to clinical practice? And we can be, for cognitive therapy for PTSD, the answer is positive. First of all, this work has been presented before, but it started with the Omagh bombing collaboration with Michael Duffy, who is at the conference, and Kate Gillespie, where we found that cognitive therapy was very helpful for survivors of the Omagh bombing. Then it was applied in London bombings again, got good outcomes. And in our NHS clinic in London, the Center for Anxiety Disorders and Trauma, we conducted 2 consecutive audits. The first one is published, the second one is not published yet. And we just treated everybody who was referred and had PTSD with cognitive therapy, a whole range of traumas, very ethnically mixed cohort of patients, mixed experience levels in the therapist, from trainees to more experienced therapists. And we found very good effect sizes. Again, they are smaller than in the randomized controlled trials, I should say, but still very clinically meaningful improvement in PTSD symptoms. And that finding we have recently replicated in a second cohort of 318 people, and it is really quite amazing. It looks like I made this up, but it is really true data from all consecutive refers. We had data from everybody, even the people who dropped out. So we get basically identical results now in the second cohort, and there actually have been quite a lot of changes in referral patterns, like we have more refugees now in the second cohort. We have people who were not involved in the original training effort and are now trained by the people who learned the treatment in the first cohort. So the results are nice, reassuringly stable, so we can be quite confident that this translates into clinical practice. And but still, over time, I think we have changed our treatment procedures still a bit further. We have continued to work on making our treatment really on target with the symptoms. And I think this result from a recent analysis that Milan Wiedemann in my group has done illustrates this. And Milan has looked at a phenomenon like sudden gains in these 2 consecutive cohorts of patients treated in London. Sudden gains are sudden change, like big changes in symptoms, similar to the ones that I showed you with the updating memory slide. So if we do things right, we can actually get big changes quickly in PTSD. And we have been, as a group, I think we become a bit more confident about using the update procedure early. So we have, if there's something that's very obvious update, so let's say I didn't die, we might actually already, once we have identified the hotspot, do the updating immediately in the same session. I know, for instance, that Jen has treated some people and even in the first session already done some updating. or in the second session when we identify these, what we could say, quite straightforward hotspots where the updating information is actually clear, the patient already knows it. And so that means that what you can see in the slide is that whereas we were probably in the first cohort, we were probably doing the updating, starting the updating more in session 3 or 4. In the second sample, we have started it somewhat earlier, and you see then the percentage of sudden gains in the first sample in dark bars and in the second sample in lighter bars. And you see we're getting the sudden gains earlier, and more of them are really early, which is really actually very motivating for patients. If they can learn very early and to know that this therapist really knows techniques where we can make big gains in symptoms, that motivates them obviously then also to stay in treatment, helps with the problem of dropouts. So that was an interesting result in this analysis, I thought, that we hadn't necessarily planned this way. We just kind of constantly working on improving our procedures. Okay, so then let me now go on to briefly mention that not only are we still working on optimizing our clinical procedures, but we're also looking as research question to really check our ideas about why treatment works. Because there is a lot of discussion. I think it's a newer discussion again. Even it was already when people starting doing psychotherapy research, it was already a topic. What's the importance of the therapeutic techniques versus having a nice, very, very competent therapist, and so on. And we have to show, really, I think, in order to be convinced that the treatment mechanism is, for instance, changing the appraisals, changing the memory characters, and changing these behaviors, we have to also being able to show that in the data, and rather than having good support by a competent therapist. And in this example here, Birgit Kleim really analyzed symptom changes from week to week, both in symptoms and in the appraisals, the cognitions that we measure with the post-traumatic cognitions inventory, which has items such as I'm inadequate, or about self-blame, or about external threat. So do the changes of the appraisals predict symptom change, or is it the other way around? And the results in the study were very clear. We can predict symptom change from the changes in cognition, but not vice versa, which is reassuring for our conclusion that we need to change the cognitions in order to change the symptoms. And interestingly, similar results have been reported for prolonged exposure therapy. Also, prolonged exposure therapy seems to work largely by changing cognitions. So now let me turn to the final question. How can we make treatment delivery more efficient? And again, this is a problem worldwide. Even if we train many therapists, like here in England, like in England in the IAPT program, there's never enough people to treat all the people who have PTSD, even in a country like England or the UK more generally. So are there other ways, now that let's assume that we have now a good way of treating PTSD, and we think we have, we don't have enough therapists to deliver the treatments. What can we do to get the treatment to other people? And people have, again, taken different approaches. Training lay therapists has been tried, and with quite good results, actually. A pharmacological enhancement has been tried, but usually these trials have actually toned down the dose of psychological therapy quite a bit. So I think the enhancement was mainly if you've done a less than optimal dose of therapy. Computerized training has been tried. But we've gone another way. We've tried, now that we really think we understand really how the treatment works, and the data seem to support that, can we deliver the treatment content, or at least part of it, in a more efficient way? So first of all, I should say that it's not that new a question, because in a very early trial we had already tried that by including a self-help group in comparison to a therapist deliver treatment in one of our early studies, and we had very bad results there. So pure self-help didn't work, and it wasn't better than a wait list in this early trial. So we need to do some, if we want to make this work, our conclusion was we need to have therapists help. The therapist is important in the treatment, but maybe some of the treatment can be delivered in a more efficient way. So the first step we took, and we had done it in social anxiety before, is to write self-study modules where some of the content of the therapy that we thought people could cope with in a self-study format was delivered in self-study modules. Here's an example from the Reclaiming Your Life module. And there's explanations, but there's also case vignettes that take the patients through the steps and how another person with similar problems had gone about doing the Reclaiming Your Life, and then how that worked for them. And we have done a trial testing these the self-study assisted treatment. We had in this trial we reduced the amount of sessions with the therapist by half. So instead of 12 sessions, people in the self-study condition only got 6 sessions with the therapist, and brought the self-study modules to this treatment so that the therapist could see what they had done, where they had got stuck, where they had problem, and the therapist could then pick up from there. And also some of the imaginary living that we do as part of the updating procedure was then done in session. And the results were very encouraging. This is not yet published, so we're going to send it to journals soon. So again, you see the wait list here in red didn't change, the chronic PTSD condition. The weekly cognitive therapy delivered over 12 weeks was in blue, and again, very good results like we had before. And in green, we now see the self-study assisted cognitive therapy condition who only got 6 sessions. So this plot compares them both at the 6-session time point, where they are better than the cognitive therapy condition. But overall, the improvement is exactly the same as in the full treatment. So that we found that really encouraging, because after the initial trial, we were not so sure whether this could work, but we were encouraged. So then again, 6 sessions maybe quite a lot of time in some contexts. So we then asked ourselves, can we reduce the therapist input that's needed even further? And we have now developed an internet version of the treatment, where actually more of the components of treatment are put onto the internet. For instance, stimulus discrimination training, and is done in a more comprehensive way, and the updating memory procedure in a done more comprehensive way than we could do it in the self-study modules. And delivery via the internet has a lot of possible advantages. People can work on them when they have time. They don't have to take time off work, or like when they have childcare and so on. They can work from home. They don't have to travel to sessions. There's also potential advantage that people may still feel some stigma around seeing mental health professionals, and they can all do it from their home, so nobody can see them go to a treatment service. And we can, hopefully, if we can reduce the amount of therapist time needed, we can treat more patients and help more patients. But again, the big question, is it acceptable and does it work? So we had to test this. We did a pilot study first. For those of you who were in the previous session, Jennifer Wild has already presented that in greater detail. So the internet-delivered form of cognitive therapy that we're using actually realizes all the core procedures in an internet version. We're using the multimedia features of the internet. So, for instance, there's a lot of therapist instruction and modeling by other patients via video, which wasn't possible in the self-study modules because that was all paper and pencil. Another nice advantage is that we can include patient testimonies. Former patients volunteered to talk about their own experience, so it doesn't have to be in writing. They can see it in a video format. There's case vignettes like in the self-study modules, and we, for instance, have a trigger library where the therapist and the patient can upload triggers, and we have special pages for updating hotspots. so on. And the role of the therapist now, I think, is, and we can't underestimate that, is quite different. So it's not like doing a full treatment session on the phone. The therapist has, first of all, can log into the program and see all the work the patient has done, can make comments right into the boxes that the patient has written to make comments, make suggestions. But also there's a safe, secure communication system where the messages get sent backwards and forwards. And they will also have a weekly short phone call of 20 minutes. So it's much more short, immediate reactions to what the patient has done, rather than reviewing it in a session, in a weekly session, in week-to-week treatment. And the phone call also has to be very focused on spotting where the patient got stuck, taking them further. So it's an interesting learning exercise, I think, for everybody how to do this. Just a few more, to give you a bit more impression about other features which are nice. The dashboard that the patient sees, you can see like the messages. Then the front there's a picture of the therapist, and you can see a new message coming in if there's a new message for you, and you can read all the messages that have sent through the treatment. On the left you have all the modules that we have worked on so far. But then on the right, you also see that we regularly, every week, ask them to fill in symptom measures and also measures of the cognitive processes that we're targeting in treatment. And patients can immediately have feedback on their progress in therapy. And for the therapist, it's very important to review this too. We talked about testimonies, case examples, and here we've made case examples for different types of trauma so that the patient can choose either one case example that's similar to their own trauma if they prefer that, or if they still very avoidant, they may prefer first to start with somebody with another trauma so that there's no reminders that could be hidden in the case example. So we've been careful to cater for both possibilities. This is the page where they can upload triggers, like in this example, the patient has uploaded the siren, which was a trigger for their memories, and then they can play this siren sound back while they're practicing the then versus now, the stimulus discrimination. And here we find the results of the first pilot study that Jennifer Wild and the team published in 2016. We had 10 patients in this trial. 80% of them recovered from PTSD with the internet treatment. We didn't have dropouts, so that answers, or it's a preliminary answer to the question, is this effective and is it acceptable? In the pilot study, definitely. The mean number of hours that the therapist spent with every patient through messaging or through the telephone calls was 4 hours, so significant saving to face-to-face therapy. And also I'd like to point out that this is like the average symptom improvement in the PCL5, which is a PTSD symptom measure. And you can actually see that the improvement was very quick compared to week-to-week face-to-face therapy. I don't know whether you remember the intensive treatment. It looks pretty much the same like the intensive treatment. And that is an unexpected finding, and I don't know whether it will hold up. But the explanation could be that the patient, if they have made the decision they want treatment now, and they engage in treatment and do work on the attended program, they can make quite a lot of progress quickly because they can work on how many modules they would like in the first week or in the second week. And importantly, if they get stuck, they get immediate feedback, so they don't have to wait for the next session. Maybe we're trying to do some reclaiming your life homework, but then they come to the second session and say, oh, I really couldn't motivate myself to do this. I really felt so depressed and so on. And we've lost a whole week, whereas in the internet treatment, the therapist can communicate with the patient quicker and get them going quicker. So that's a post-hoc interpretation. We have to see whether this holds up. We have now started a new trial where we put the treatment to a proper test in a randomized control trial, and actually we set ourselves a very tough comparison. So we're collaborating with Professor Gerd Andersson in Sweden, who has developed a non-trauma focused CBT program that's very comprehensive, a stress management program. And we have written, in particular Hannah Murray and our team and the whole team have rewritten the modules that are in the general stress management treatment to fit to PTSD. And we're basically randomizing people to one of these CBT treatments. And there's also a small wait list to see whether we're actually doing better than wait list, because I think that's always important in PTSD trials. We have recruited about 50 patients now, and we need 175, so it will be a while until I can give you the answer. We are quite excited about it. It seems to be working well, and we hope to be able to present the results in a few years' time. So let me then finish with saying, just summarizing, I think with what I've covered today. First of all, we've seen the increase in efficacy on trauma-focused CBT treatments over time, but as we will test in this trial, non-trauma-focused CBT programs also may play a role for some patients, and we'll know about that. More of the NICE guidelines have also looked at that in greater detail recently. So trauma-focused treatments are working well, and I think it is because our group, but also other people in the field who have developed these treatments, have focused their work more on trauma memories and their meanings, and as progress making the treatments more acceptable. We can make the treatment more efficient, either by self-study modules, and I should say that we will make these self-study modules available on our resources website that we are creating from the Oxford Center for Anxiety Disorders and Trauma. When the trial is published, I have to wait until then. It has to go through a review first. But they might be useful for your own clinical practice, or also for training a new therapist in the cognitive therapy for PTSD approach. And the initial results on making the treatments more efficient by delivering by the internet also seems promising and feasible, but at the moment we have to say we have to await further evaluation to see how well they work, how acceptable they are in a kind of larger sample, and whether there's, for instance, how big the differences are between trauma-focused and non-trauma-focused CBT. Thank you very much for your attention.
We have time for just one or two questions.
I'm just curious, how do you think it'll compare to medications? It looks like you're getting very stable. Oh, my bad. I'm curious how you think it would compare to medications. It looks like you get very stable change. I don't see those lines bouncing back up after treatment's over in your follow-ups. And in the States, a lot of folks get medicated for PTSD, and when you stop the medications, it looks like it's still there. What would you guess there?
Yeah, so that is true. The longer-term follow-ups have shown that the effects are stable, and we also, I think, clinically find that when people have successfully gone through the treatment, they are better able to deal with new stressful events that are come up, which unfortunately happens. Medication comparisons, we haven't done a direct comparison, and we'll hope other people will possibly pick that up. I think that is important to do, because the populations that are treated in pharmacological studies may differ in some ways that we're not sure. But overall, I think the results in PTSD are pretty clear that the trauma-focused CBT programs in general have better outcomes than SSRIs. And so that we would expect the same pattern, and hopefully also then be able, and we would then presumably also find the same effect, that if people withdraw from medication, they relapse, whereas they have learned skills that they can apply to in the long term in the trauma-focused CBT.
Hi, is there a rationale at all if people do drop out to offer them EMDR? Is there, sort of interested in the link between treatments? Is it the case if somebody can't engage in reliving that there'd be a kind of clinical rationale to offer them EMDR?
Yeah, I can't speak from experience there. I think it is possible that some people who don't respond to this treatment then seek EMDR and do well. We have seen the other way around as well. We have quite a few people who have had attempts to do EMDR and then didn't, or got somewhat better, but then actually had still quite a lot of remaining problems or didn't respond, and they come to us. So I think this is unfortunately all quite anecdotal, so I can't really make a kind of good judgment on that. But I would also want to say that we never give up on our patients, because in the NHS clinic we had quite a few examples of people who had an unsuccessful attempt initially at the same clinic, sometimes with an earlier, more exposure-based treatment there, but also in our clinic. And when they then get referred, sometimes you just catch them at a better time in their lives. So people with PTSD often have many things going wrong in their life. They don't have housing problems and relationship problems, childcare problems, and so on. So sometimes they are just too overwhelmed with their everyday life problems to really go through with the type of engagement we need. So I think it's not necessarily to say that you have to then definitely do another type of therapy. So I think the answer is open, but we and whether they should have, or we should offer a non-trauma focused treatment that they might engage in more. So I think probably you have to make an individual decision what it was that made them drop out and what the next steps should be.
We'll take one more question.
Thank you, that was a great presentation.
Oh, thank you.
One clinical question which is related in some way. So obviously as a clinician one wants to do the reliving fairly early, but when would you exclude someone from that as a therapist because you would think they weren't resilient enough or stable enough to do the treatment?
Yes, so our general approach has been to do kind of facilitate the engagement with trauma memory really early on, and we haven't done a stabilization phase or something that's sometimes recommended. So we would adapt the way we do the engagement with the trauma memory to make it fit to the patient. So let's say somebody is dissociating a lot, and we have quite a few patients who do that. We prefer to work kind of with a trauma narrative, writing a trauma narrative together very slowly and with a lot of stimulus discrimination first. So you could say that that's something we would do before. We would do stimulus discrimination first, so change the order of interventions around a bit. But try to get that, because that's why people came to treatment for us. So we have done well with that. But I mean, you might have certain presentations. Let's say you have somebody who has like full-blown borderline personality as well as PTSD. That the answer might be slightly different because you might want to do more skills-based treatment first. But a lot of our patients have borderline features as well, or may have had a diagnosis of borderline personality disorder in the past, but are currently the decision is that PTSD is the main problem. So I'm speaking about that kind of cohort, but in that we have made had good results, and we don't really teach relaxation or other coping strategies first.
Thank you. I realize there are more questions, but we've run slightly over time. So I'd like to take a moment to thank Anke Ehlers for an excellent keynote. Thank you.